So my name is Emana. I'm a fourth-year medical student from Southeastern University. So today we'll be reviewing a case. The disease, its manifestations, its symptoms, they're not so unusual to encounter. But what makes this case important and unusual to present is how silent and aggressive, how quiet and silent such an aggressive condition had presented itself. So honestly, if it weren't for patient compliance, showing up for his follow-up, the aggressive nature of his disease could have led him to permanent, even fatal consequences. So to set the background a little bit, diffuse large B-cell lymphoma, DLBCL, is the most common non-Hodgkin lymphoma subtype. It's notoriously aggressive. It commonly harbors in the gastrointestinal tract, as it did with our patient, but what's important to note is that DLBCL is actually curable, especially when diagnosed early. Aggressive treatment is initiated. However, when it begins to encroach into gastrointestinal structures like the small bowel, it very well decreases the overall survival rate of these patients. It's very aggressive, it's quick to grow, and patients often come to the ED complaining of immense abdominal pain. They're in pure discomfort, they're in distress. And actually, this was quite opposite with our patient. He was a 55-year-old veteran male. He had a history of mesenteric non-Hodgkin lymphoma. He was actually 7 months post-chemotherapy and post-surgical resection and biopsy of a previous mass. And Dr. Stone, his surgeon, my mentor, was very active in encouraging his patients to follow up, outreaching his patients through phone calls, and as a result, maintained very good patient compliance. So this was actually during my clinical rotations. We saw the patient at first glance. He was so pleasant, so kind, no complaints of pain. On exam, physical exam, he presented with no acute signs of obstruction or peritonitis, no guarding, no rigid abdomen. So then he was sent down for his imaging and his blood draw. So this is actually where everything took a 180 turn. The patient didn't even expect that day he'd be rolled down to the OR that day. So in figure 1 in CT with contrast, it showed a cystic mesenteric mass, and the same area in figure 2 on PET scan had glowed. This was actually the same site of where his previous lymphoma mass was. So it kind of worried us, okay, maybe there is some sort of recurrence of his previous lymphoma. And then on his CBC, he had a hemoglobin of 1.8, which suggested to us severe anemia. And even though just during the encounter, he was so calm and so pleasant, it was his imaging and his labs that raised suspicion for us and worried us for threatened bowel, possible intestinal perforation. And this prompted our decision for immediate exploratory laparotomy. Upon laparotomy, the mass was identified. It actually involved the proximal ileum. The mass was freed. The proximal ileum was actually perforated, and along its mesenteric border, it eroded so much that it created an opening for drainage to form a necrotic abscess. So this area was washed really well. It was cleaned very well. The mass was sent for path evaluation. And grossly, the ileal perforation was directly caused by the mass. It had invaded into the bowel wall mucosa. And in figure 3, I have the histology photos, the mass stain positive for CD20, CD10, BCL6, 3 stains that are very well associated with DLBCL. CD20 is the gatekeeper of B cells. Clinically significant is that it's a very great therapeutic target. BCL6 is a transcription repressor on the germinal center of B cells, and clinically it's significant in helping practitioners evaluate potential patient prognosis with their DLBCL. So BCL6 is actually indicates a more favorable prognosis, predicts a more favorable prognosis versus its counterpart, which is BCL2, which does not. And CD3 was used as a differential stain, which the mass did not stain very well for, so it didn't indicate to us of T-cell origin. So results confirmed recurrent high-grade mesenteric lymphoma. So the patient recovered post-operatively slowly but surely. He's actually doing very well. He's still very good, showing up for his follow-up. So ultimately, this case really highlights the importance of encouraging routine follow-up care, especially in previously treated treated cancer patients, patients in remission, especially to improve their prognosis, but also make appropriate and immediate medical decisions when acute symptoms are presenting silently. For example, our patient with a surgically acute abdomen that we wouldn't have even known if he didn't show up. And that's pretty much my presentation. I'll open it up for any questions.